mean, the most important biochemical parameters are the accumulation of copper into the liver that can be measured in a biopsy, but also biochemically in blood tests we can have low ceruloplasmin levels and increase urinary copper excretion, because as I told you, the copper goes into the blood, and from blood it goes to the, it's filtered by the kidney and goes to the urine. And these are the three main, I would say, the three main parameters. So in this case, this is also a gene that fits into an AAV, so we decided to go to use an AAV vector. In this case is serotype 8, which is a new serotype that is believed to be more efficient for liver transduction. The first one I showed you was serotype 5. But anyway, so we have this ITP7B gene, and then this time we use also a liver-specific promoter. And then the good thing is that we have also a knockout model, an animal model that recapitulates most, although not all, the symptoms of the disease. This is what we call the Wilson disease mice. So in these mice we can do all the preclinical testing. This is just to show you that in these animals, as you can see here, in white is the control healthy mice. These are in gray, in light gray, the Wilson disease untreated mice. You can see here that at different ages, these animals accumulate, excrete a lot of copper into the urine, as it happens in patients. This is a biochemical parameter very typical in patients. And you can see here that even at low doses of the treatment of the virus that was injected intravenously, we can reduce the excretion of copper into urine. And this effect is maintained over a long period of time, more than 6 months. Also, liver damage is an important characteristic. You can see here that the Wilson disease animals have increases in transaminases, which is a biochemical marker for liver disease, and that even the low dose of virus can really protect the liver from the damage. You can see here in the transaminases, and also in liver histology. The liver histology in these animals is terrible. They have really altered histology, and the treatment really restores this histology to normal. Also, we can restore the ceruloplasmin in serum, although for normalization of this parameter we really need a high dose, so this parameter is more difficult to correct. But probably one of the most important things is that we prevent the accumulation of copper into the liver of these animals. As you can see here, the quantification and the staining for copper in a mouse with Wilson disease. This dark stain is copper, and we normalize this with the treatment. So as a conclusion, I would say that gene therapy offers a causal treatment for, I would say, for most metabolic diseases, and that the liver is a suitable target organ for in vivo gene therapy for many of these diseases. Technical improvements in vectors will increase the chances of success in these diseases. But still, at this phase of gene therapy, the risk-benefit considerations are very important to perform clinical trials in which, as I said, there are chances of success and the risk is affordable. But I would say that once this is done, once this initial phase in this field is accomplished, and the safety is consolidated, I think most metabolic diseases will be good candidates for these kind of therapies. So we at Thema we work in two different platforms. One is the AAV vectors, and the other one is the helper-dependent viral vectors. This is our core, let's say, expertise. And then, depending on the availability of projects and funds, etc., we can apply this technological platform to different diseases. As I have shown you here, examples about porphyria and Wilson disease, but we are also planning primary peroxaluria, and maybe some other projects still not started. What I mean is that this is a core technology that then can be rapidly applied to different diseases, just changing the gene. And if we have a good animal model, that can go rather fast. So yeah, I just want to thank all the people involved. Of course, I have talked about 2 different projects. The Porphyria project was led by Antonio Fontanellas, and I have to thank all the people in the IPGene project. Here, this is a picture of the people that are involved in the Wilson disease project. This is Gloria Gonzalez, which is the director of our gene therapy program. And thank you for your attention.
Thank you very much, Dr. Hernandez. Please come and have a seat here. Dr. Subio and Professor Buchan as well, as the speaker of this afternoon. Are there any questions for the speakers? There's a microphone on the way.
Thank you so much. The point of view of the families affected. I was in Chicago meeting in 2011, and I asked about the possibility of a liver transplantation for cure this disease, and el consensus was that the risk benefit of liver transplant, because the anti-rejection medicine did not explain or no aconsejaban the liver transplantation, because CDCA was better medicine than anti-rejection medicines in this case. Okay, so now we are talking about gene therapy, that I think it's very interesting, and I am asking if liver transplantation in this disease, do you think, maybe you don't know, I don't know, see if you think that liver transplantation maybe be a cure for CTX problem, in spite of the anti-rejection medicines. So we can have an option for gene therapy. I don't know if I explained myself. Okay.
Ingemar, do you have an opinion on that?
Well, personally, I believe that the risk-benefit ratio is such that one should not make a liver transplantation. I think the mortality in such an operation is 5% or something like that. And you have a therapy, and if that therapy is not effective, then the reason for this is that there's already been irreversible changes that would not be better after transplantation, according to my opinion.
I guess the point is that the experience of patients in which the disease keeps on progressing despite the treatment. I guess it's not a matter of gaining the function that you have lost, but at least stopping the progression. And when it does not happen, I can understand that people wonder if there is something else that can be done. Because some patients are in the middle age, in 30s and 40s, and they are deteriorating. So I guess this is the point, right?
So in any case, if liver transplant wouldn't work, then gene therapy wouldn't work, right?
if liver-directed gene therapy wouldn't work. Yeah, that's why for us it's a criteria. But as I mentioned, I mean, if liver transplantation doesn't work and liver-directed gene therapy doesn't work, that would be because we have to really look at the brain directly. So then we will have to think about brain-directed gene therapy in this case, which, as I mentioned before, there are vectors that can go both to the liver and the brain, so that would be one way to go. But I think we really need a lot of basic research before we can answer these questions.
Yeah, so did you understand the thing? So the point is, we are not 100%...
A lo mejor lo decimos en español o...
Sí, I'm just going to repeat and summarize para los pacientes que necesitamos estar seguros de que corrigiendo el problema en el hígado, la enzima no funciona en el hígado y que se sepa la principal función, pero probablemente no la única, de la enzima está en el hígado. Entonces, corregir el problema en el hígado va a prevenir o corregir o frenar el problema neurológico. Hay una sospecha alta de que sí, eso es por lo que se entiende, lo que estamos entendiendo hasta el día de hoy de la enfermedad. El que no funcione bien esa enzima en el hígado hace que se acumule el 4C, el intermedio de que habló Ingemar, el cual posiblemente va al cerebro y produce el resto, pues se sintetiza colestanol y se acumula el colestanol. Eso es nuestro entendimiento hoy en día de la enfermedad. Si eso es así, entonces corrigiendo el problema del hígado de alguna manera debería ser eficaz. Y podemos corregir el problema del hígado trasplantando el hígado, poniéndole un trozo de hígado que tenga la enzima, o a través de terapia génica dirigida al hígado. Y lo que Rubén estaba explicando es que si trasplantando el hígado o haciendo terapia génica dirigida al hígado no se corrigiese el problema, la enfermedad siguiera progresando, significa que algo está pasando en el cerebro que no entendemos bien y que algo más, que algo distinto del enzima, y que a lo mejor habría que pensar en terapias dirigidas directamente al cerebro, terapia génica dirigida al cerebro, que ya es más complicado y tal, ¿no? Bueno, no sé.
No necesariamente,
pero es otra cosa.
Pero bueno, un poco lo que quería decir es que depende un poco, como os decía antes, ¿no? Todo depende de los vectores, es decir, el gen va a ser el mismo, pero habría que cambiar el vehículo. Y esos vehículos existen, hay vehículos que pueden ir al cerebro, es decir, por ejemplo, en Barcelona hay un grupo de Fátima Bosch que están trabajando en mucopolisacaridosis, en otro tipo de enfermedades, en los que ellos proponen el ENDTALK serotipo 9, por ejemplo, que aparte de ir al hígado, va al cerebro. Entonces, no sería, a lo mejor sería un poquito más, más complicado o menos, pero depende de con quién hables, porque para un neurólogo lo fácil es ir al cerebro, para un hepatólogo es ir al hígado, pero no creo que sea una complicación mucho mayor si se utiliza un vector seguro, que yo creo que el ENDTALK se va a demostrar que lo es.
Pero a día de hoy hay mucha experiencia con vectores que van al hígado y que parece que están funcionando con seguridad, y claro, si pudiera corregirse el problema en el hígado, pues parece que se vislumbran oportunidades. But still, my point with the discussion of whether liver transplantation is, the risk-benefit ratio is okay, is if liver transplant doesn't work, then liver-directed gene therapy will not work, because it's the same. What we're trying, the target is to have the enzyme replaced in the liver somehow. Unless there is another, reason for the liver, for the transplant not working. I mean, rejection or other issues. So I'm not sure. So okay, liver transplantation is risky, but how about gene therapy? Well, gene therapy seems to be safe. Sure. I don't know. So
I would say that especially in a few, not in a few years, I would say, or even earlier, we will be sure. I can maybe say for sure that liver-directed gene therapy is safer than a liver transplant. So what I mean for this is that for this kind of diseases would maybe be wiser to start with gene therapy rather than trying to do a liver transplantation with all the risk of immunosuppression and surgery and everything. But that's my point of view.
Well, I agree with that. And the question is, for some patients, can they wait a few years? And the second thing is that, basically agreeing with that, but it's also good to remember that we are not talking about taking out the liver and putting in another liver. We just need what is called an orthologous transplantation, which means they need a piece of liver that produces some enzyme.
Yeah, that will lessen the morbidity of the surgery, but not the risk of immunosuppression, which is a long-term risk of liver cancer and things that are chronic.
Yes, of course, but long-term risks are risks that we care about in patients that are going to have
No, of course.
A few years neurological deterioration. I'm just saying I'm not sure that the risk-benefit balance is not reasonable. I'm just not sure.
I'm not an expert on liver transplantation, but of course, I guess that if anything, should be partial.
Of course.
Supplementation of.
You don't even need to remove anything from the patient. You just need to put a piece of liver from a relative, right, to reduce.
And just talking about gene therapy is a discipline very related to cell therapy nowadays, and there are other approaches that now that I've heard talks about the apheresis. I know you have heard about artificial liver, in which you have like a device with hepatocytes, sometimes are derived from pig or human, in which you basically it's like an external liver that can be used to detoxify. I'm just talking about theoretical things, but that would be another potential approach.
I'm not sure, because that external liver, so our liver has one detoxifying function, and then I don't know if that for this metabolic function it would work. I'm not sure, but it's too bad that Dr. Gomez couldn't come in the end, because he would have been able to answer some of these questions. Maybe I can translate them to him and then email them to you. These are open questions. I don't know if we could find that out or try that out in some volunteers. The only thing I suppose in some volunteers who cannot wait 10 years or 5 years or whatever, it would be reasonable to, that's my thought. I think it's not unreasonable to as we doctors, we are using what we call compassionate treatments all the time for patients where we don't have anything else to offer, and there is something that is like in borderline between something that is has a demonstration that is useful and not doing anything. So I
have a comment. In principle, this disease is due to the fact that the patients cannot make the proper bile acid in the appropriate amount, and then you could treat in two ways. Otherwise, one way is to replace the liver. Then that problem will be eliminated. But it's also another way is just to compensate by giving the bile acids that are needed. And in that situation, I think you should use the bile acid substitution therapy. And that is what we are doing.
Another interesting question is that perhaps, I don't know if the bile acid substitution therapy from some point of the disease course on doesn't work any longer. I don't know, maybe when the generation is already advanced or when we started too late, maybe in those situations liver transplant will also not work. That's another good thing that we just don't have answers for that. Maybe liver transplant, in case that would be reasonable, maybe it would have had to be done earlier. We just don't know.
And then liver transplantation analogous to adrenoleukodystrophy, hematopoietic cell transplantation in the cerebral form, does not prevent myelopathy after decades of transplantation. So perhaps liver transplantation is second best therapy if we think about it to bioacid therapy.
Yeah, but on the other way, for some other metabolic diseases with neurodegenerative associated manifestations, it has been used successfully, or with the risk. So it has been used before. It's not the first time that it's been talked about, right?
Professor Federico?
Now, a question to Susie about the patient with spastic paraparesis and atypical molecular abnormalities. Have you some data on the parents of those patients from a molecular point of view? And have you checked, for instance, cholesterol and bile acids in urines and serum?
We do have information on basically all the parents, and most of the cases are sporadic, and the parents are neurological. From a molecular point of view, yeah. Most of the time they do have all the times actually, none of them is a de novo mutation, so the mutation, most of these individuals are heterozygous, except for that one that has 2 mutations, and the mutation comes from one of the healthy parents. There's one case where or 2 cases maybe, where there's a dominant HSP with other diagnosis, and we haven't checked other family members. So other family members have the mutations in general, and no, we haven't done any biochemical assay or on them yet. We just didn't have time. We have been discussing this over lunch. Maybe we should. I don't know if with all. I mean, maybe for some of them, definitely this is looking at any metabolic marker that we could have available would be useful, I think. Maybe not for all. I don't know, for some of them that have silent mutation and another SPG causing mutation, I don't know if it's worthwhile. But for those who have one missense mutation and otherwise no known genetic defect that we have found so far, in those cases I would do, and definitely in the compound heterozygous. But we haven't done that yet, so that's probably the next step. Let's see how we can arrange it, because the patients are from different parts of Spain, and we have to talk to their physicians and arrange everything, but this should be done, yes.
So I have a question for you. I have heard about genetic analysis and biochemical analysis, and still there are some lack of correlation between phenotype, genotype, and biochemical function. What is the role of proteomics on all of this? I mean, has been done? I mean, what about the protein function, enzymatic function? What about the level of enzyme produced?
Maybe Ingemar, you would probably answer that question better than me. Maybe I'm not aware that the protein has been looked at in an omic fashion.
Not necessarily in an omic, but just studying the amount of protein produced, the enzymatic activity of this.
Yeah, that has been studied, but it's in many of the published cases, but it's not like a routine test that it's doable. It's not at our reach. I don't know if in other countries or places they look at the level of protein in, let's say, in patient fibroblasts or so that can be done, looking at the amount of protein or looking at the enzyme activity, and that's what biochemists know how to do. But I don't think that's routinely done, other than out of.
Could you explain some of the discrepancies between?
Yeah, very probably. Actually, not all the mutations seem to affect the protein level in the same way, as I was very quickly recovering from some literature, and not all the mutations seem to affect the catalytic activity of the protein in the same way. So that probably can be part of the explanation of why there's so little correlation. But then there's the other intriguing thing that I think Dr. Federico mentioned, or someone today, that there's also maybe it was also intrafamilial variability in the phenotype. And so how do you explain that? Because then you do have the same mutation combination, and so that cannot be the only explanation, but it definitely is probably part of the story, and it's, as far as I know, it's not studied as on a routine basis, but I don't know.
We have made some preliminary studies trying to relate the mutation to the clinical pictures of CTX, but we failed to get any good correlations there, and I think there are so many other factors that could affect the clinical pictures. As you said, that even the same mutation could in the same family could give very different clinical pictures.
Yeah, in relationship to the correlation between the molecular genetic changes and biochemical changes, for instance, there is some studies we have done some times ago about cases with deletion, big deletion of gene and the protein. There is a severe protein abnormality that impair the protein function. But this deletion that we have found first in the classical phenotypic presentation has been found also in a case with very severe infantile form of childhood so-called hepatitis. So it seems that there is very few correlation from a biochemical and clinical point of view. So perhaps other factors may influence. But what is common in many neurometabolic diseases is the intrafamiliar phenotypic presentation, because we know in adrenoleukodystrophy, metachromatic leukodystrophy, Krabbe disease, in all the neurometabolic disease, that the same gene will influence differently the clinical presentation, even in the same family, with some cases with very fast evolution and other cases with a very slow evolution. So the clinical heterogeneity is a general problem of neurometabolic disease, and we don't know which is the regulation, epigenetic or other gene that is possible that will regulate the action. But even, in my opinion, the sex may influence the phenotypic presentation. We have many data from the clinical experience and even from the literature. For instance, in Cadacil and the other form we know now, which is the some data in Huntington or other neurodegenerative disease. We know that the genetic inheritance, maternal or paternal, may influence the phenotypic presentation. So we start to have some data that even sex may be an influence on the phenotypic presentation and type of inheritance.
I just have a comment on the complexity in the situation in CTX, because it's evident that the mutation will reduce very much the formation of kininoxycholic acid, or almost zero. But the patients have a relatively low reduction in the production of cholic acid. And the reason for this is that there is a pathway, normally a very, very minor pathway, involving 25 hydroxylation that can create bile acids. But the only bile acid that is formed with that specific pathway is cholic acid. And cholic acid is not normal, but perhaps it's reduced only by 30-40% in patients with CTX. And if that cholic acid is then converted into deoxycholic acid in the intestine, then the deoxycholic acid will substitute for quinone to some extent. And if you have that situation and perhaps you have some more active